All right, good morning, everyone. Thank you for joining us for the Global Critical Care Fellows Seminar Series. Today, we will be talking about managing pain in critically ill patients. We, myself and two of my colleagues from Johns Hopkins in the Division of Regional Anesthesia and Acute Pain Medicine, are going to walk you through how to approach these patients. So we'll each do a few lines of intro. I'm Kellie Jaremko. I'm the new program director for our Regional Anesthesia Fellowship. I trained at Johns Hopkins, and I'm interested in researching managing pain in patients that are vulnerable, such as after trauma and those that are critically ill. Dr. Segna, would you like to say a few words?
Hi there. My name is I'm Segna. I'm the medical director for regional and acute pain at one of the sister hospitals for Johns Hopkins. It's called Bayview, and I do a lot of research. I have a R01 grant looking at peripheral nerve injuries, and I teach a lot. It's really nice to be here today.
Dr. Prasad?
Hi everyone, I'm Rashmi Prasad. I also belong to the acute pain regional division and additionally the ambulatory division. I am the medical directors of a few of the surgery centers that are under Hopkins. My clinical work, I'm interested in, of course, outpatient surgeries and acute pain management for outpatient surgeries, including regional anesthesia. And kind of I held many workshops at national levels to train people in different regional anesthesia techniques. It's great to be here today to talk to you all.
We're so excited to have you all here, and thank you for the introductions. We're going to go ahead and get started. One second here. So none of us have any conflicts of interest to disclose, and we're just going to quickly go through the learning objectives. So today we want to talk to you about pain in the ICU so you understand the prevalence and consequences of undertreated pain. We know there's obstacles to treating these patients' pain because of how complex they are. So we're going to go over 4 categories of obstacles to adequate analgesia in these patients. And then we're going to discuss the role of personalized, evidence-based, multimodal options, and that's also going to include regional anesthesia. So you can really put together a personalized plan for your patients. So this is an unfortunately common scenario that we have. We have patients that have baseline stable medical conditions, just going about their day-to-day lives with their psychiatric and medical comorbidities handled. And then something changes. Either that's an accident, perhaps cancer, some sort of major surgery, or a new life-threatening condition. And this lands the patient in the ICU. And now they have multiple different organ systems and issues going on, as well as the effects of their chronic comorbidities, which are hard to manage in this setting. And our goal is to try and make sure that we help them survive through the process, but also that their pain is controlled and that hopefully after they're discharged, they have recovery and don't end up with a lot of disability from this unforeseen situation where they were critically ill. So we know that pain is a part of being in the ICU. The sources of pain vary and can be post-traumatic from the injury or initial insult. They can be perioperative, so after major surgeries such as esophagectomies and thoracic surgeries, we know that that can be best modified and watched in the ICU. And then, of course, in the ICU, procedures are done, such as lines and turns and dressing changes and many things that have a source for pain. And these things all are intertwined in the pain experience. So in 1990, there was a large study of over 6,000 patients from the ICU across multiple centers, and it's called the Thunder 2 Project. And they looked at pain in the ICU, the prevalence, and how to predict it. And they found that 63% of patients recalled moderate to severe pain when reflecting on their ICU stay. When they were asked in another study to describe their pain experience, 20% described it as bad, awful, and 6 to 13% described it as fearful, frightening, sickening, punishing, and cruel. And so you can imagine this is a very stressful nidus for our patients in these situations. So we're going to go with our first poll, and there should be one in the Zoom, so feel free to click through. Based on this project, the Thunder 2 project, they looked at which intensive care procedure was rated as the most painful and distressing. So I'll give you guys a few minutes to click through. The options, and this is in adults, are wound care or dressing changes, tracheal deep suctioning, turning the patient, central venous catheter placement, or femoral catheter removal. Go ahead and start putting in your questions, and we'll just give you a few seconds here. Awesome. We've got some answers. Any last minute answers here? So, most popular answer here is tracheal deep suctioning and wound or dressing changes in non-burn patients. And let me share those results. You guys can see that. And so the answer is actually C, turning the patient. And I know that this is a little bit surprising. What they found is that in adults, turning the patient was the worst. And if they already had additional pain at baseline, so after post-surgical, post-trauma pain, 96% of the time they had a doubling of at-rest pain with turns. And then they also had an additional 36 that were reporting pain from medical devices such as central lines and suctioning. And as you can see here, you can see the average pain scores for the different procedures. Notably, in adolescent patients, wound and dressing changes was the most distressing and painful for them. Okay, so what are the consequences of uncontrolled pain? In the short term, we know that pain can worsen delirium. It can prolong mechanical ventilation because of dysynchrony with the vent due to rapid respiratory rates in uncontrolled pain. And we know that prolonged mechanical ventilation or poorly controlled pain results in a longer ICU stay. And these things interact with each other because when they're in the ICU, again, we have all these obstacles to potentially controlling their pain. Long term, there are significant risks to poorly controlled um, pain in the short term that can lead to increased pain, functional limitations, and lower quality of life. This was seen in several studies at both 6 months and 1.5 years. And we see that there's such a thing called post-ICU syndrome. So this comprises physical, cognitive, and mental impairments in ICU patients. And it's of note that survival in the ICU does not equal full recovery. The incidence of this syndrome is between 50 and 80% at 3 months after ICU discharge. So the physical issues with this are ICU acquired weakness, neuropathy, functional disability, and chronic pain. Cognitive effects can be memory, executive function, language, attention, and visual spatial abilities that are affected by their time in the ICU. And then the psychological or mental impairments, there's significant anxiety, depression, and PTSD. In one large study, they found the severe PTSD prevalence was 25% in these patients. This tends to get better over time, but the chronic pain that affects up to 77% of these patients can be quite debilitating. And so if we control their pain early on, we should be able to prevent some of these morbidity and mortality things. And because of the comprehensive nature of post-ICU syndrome, these patients actually have higher mortality than their counterparts that don't have the post-ICU syndrome. Pain is a large part of this, so that's something that could potentially affect the mortality of our patients. So this is just an open-ended question to kind of think about, but feel free to type in your answers. What are some reasons that pain may not be well controlled in the critical care setting?
Where are we typing in the answers?
There's a new poll. Launch it. Here we are. Okay. So just give you guys a few seconds to type in some answers, and we can obviously discuss this at the end. We're going to go through 4 categories, but it's just good to think about what you've encountered in the ICU that may have been an obstacle for these patients. And I'll keep the poll open for a moment while I go to the next slide in case anyone wants to throw in any answers. All right. So, when thinking about the obstacles to adequate analgesia in this population, there are four areas that could be affected. And so, we're going to go through those. One is the inability to communicate. One is multi organ involvement that can affect our medication and procedure choices, exposure to high dose opioids, and psychological distress, as we already said. Let me end that poll to this. Okay. So, with regard to inability to communicate, there's multiple reasons this can be in our ICU patients. For those that are mechanically ventilated, we know that there can be high requirements for sedation and when they're intubated to tolerate the vent. And then we also know that delirium is a part of this. We already know that pain affects delirium, but so does just being in the ICU. The more lines, tubes, sedation can all affect delirium. And because these patients are not as able to communicate with us, pain assessments that we traditionally use on healthy patients on the floor as an outpatient don't necessarily apply and reflect what's going on with them. So there are these guidelines for the ICU that span across all different areas of ICU care, and they're the PADIS guidelines. They were updated recently. And their suggestions for these are with regard to sedation, avoid deep sedation and benzodiazepines. Lighter sedation with a RASS level of -2 to 1 had significantly improved outcomes in a large randomized control trial. The choice of sedative also matters, and a few trials with dexmedetomidine have shown that because it has an analgesic component, you need less additional medications for pain in that. We also know that delirium is problematic, so we need to do our multi-component treatment. That means orienting the patient, having them at a window, having family members bedside, removing lines when you can, and then using pain assessments. So we need to increase the frequency of assessments and use those that are validated. So this is a hierarchy of different pain scales. So numeric rating scale and the visual analog scale are those that we typically use in our healthy patients. And then there are a few ICU validated scales I'm going to briefly show. And then obviously you can look for the Wong-Baker face scale, and vital signs may have a role in determining this, but they're not as reliable. So these are the two validated pain scales that are commonly used in the ICU. One is the behavioral pain scale that has 3 dimensions and a rating system there. And the um, critical, sorry, second here. The critical care pain observation tool has 5 dimensions, and this includes a vocalization dimension. When they did head-to-head studies on this, they found that the CPOT was more reliable and had more discriminate validation. So these are options that you can use to try and get a better sense of their pain to treat it. Multi-organ involvement is something that we think about in these patients. Their vital signs, their liver and kidney function is varied, and cardiac function throughout their stay. And so we know this affects absorption of medications and metabolism of them, the safety of certain metabolites and medications, and coagulopathy or infection can also limit procedural access. And so those are things that my colleagues are going to talk about. Briefly touching on medications, we know that there are significant high dose opioids exposure in these patients. And so this can lead to tolerance. We know opioid induced hyperalgesia can make things worse. And we have to be aware that there's iatrogenic withdrawal risk from high dose opioids during the ICU. Up to 16.7% were reported to have iatrogenic withdrawal and opioid withdrawal syndrome once they went to the floor. So it's important for us to engage all of our other options to help with their pain. And lastly, we've talked about this a little bit, but psychological distress kind of worsens the pain experience. If they had trauma leading up to the surgery, whether that's cancer or an accident, they may be having those flashbacks and anxiety related to that. And then pain can cause poor sleep, which can cause delirium, which can affect your emotions. And a lot of patients report having feelings of helplessness, fear, and anxiety. And all of these things can ramp up their pain experience. And so we know that pre-existing psychiatric conditions are often in these patients, but they can't get their medications because they're often a PO or oral medication that they can't tolerate in the setting of their critical illness. And so they're vulnerable to chronic pain because of poorly controlled pain and psychological distress related to this whole experience for them. So it's important for us to address that. So briefly to summarize the obstacles to potentially controlling pain in the ICU. That we have to recognize that our patients are not going to be able to communicate as well as our healthy patients on the floor. We should be utilizing light sedation. We should be preventing delirium and helping reorient them at all possible. And we should be checking for pain scores during procedures, even those as minimal as turns, and treating them appropriately using scales like the behavioral pain scale and the critical observational pain scale. We know that there are multi-organ involvement, and we have to be aware of that. Engaging your acute pain experts in pharmacy can also help you assess the safety of certain medications. And my colleagues are going to start talking about the way to personalize this. We have to be mindful about the dose of opioids that we're using and try and use other medications as well. And then know that we need to watch for high risk of withdrawal syndromes and have them be counseled so this doesn't lead to chronic opioid use. And then we have to provide psychological support during their stay and recognize that sleep and other aspects of this really do play into their pain and their risk of post ICU syndrome. So I'm now going to hand this over to Dr. Segna, who's going to talk about multimodal aspects of pain here.
All right. Good morning again, everybody. I'm going to be talking mostly about medications, but we're going to start off with a question. Kelly, if you don't mind opening a poll for us. True or false? Narcotics are not a part of a multimodal therapy pain plan. Okay, everybody chose false. You are correct. So although developing a multimodal plan, and you can go to the next slide, Kelly, is important, you can, and we do want to spare narcotics. Narcotics still have a very important role to play when treating traumatic pain and surgical pain. This is an example of this slide of what kinds of things come to mind when you are creating your multimodal approach to treating pain. And the whole point of it is that instead of giving a patient like one massive dose of a medication, you give smaller doses of multiple medications, and that treats different pain receptors in the body and can limit side effects. So medications would include nonsteroidal drugs like Advil, muscle relaxants, opioids, NMDA antagonists, local anesthetics, whether it's in a nerve block, subcutaneous, or an infusion, gabapentinoids. And then there are different interventions. So you can do nerve blocks, girls, or major interventions like spinal cord stimulators, trigger point injections in nature, but it's more of a chronic pain, and various other neurolytic procedures. I also included here education and communication because it is very important for your patient to understand to have expectations set because that is basically how we get into a lot of trouble if they don't know how to use those pain scales, if they think they're supposed to have zero pain and they don't, it can lead to overreaction. Next slide, please. So multimodal plans, they improve patient satisfaction, they provide better pain control and can possibly shorten your hospitalization, and they reduce adverse effects such as respiratory depression, sedation, and also help with those who have central sensation, taking chronic opioids, and it also can lead to decreased tolerance and decreased diversion. Next slide. So I just have one slide here. We're going to go to a whole section on regional anesthesia, but this does include epidurals. It's both thoracic epidurals up high for trunks and low lumbar for like delivering babies. There are other types of truncal blocks we'll go over for the abdomen, peripheral blocks for the arms and legs. And then you have lidocaine infusion. So for my patients that are not a block candidate, for whatever reason, say they're on major anticoagulation, if their liver function is okay, I will do a lidocaine infusion for 48 hours. Though at many institutions, it can go longer. And then a surgical field infiltration has been helpful, at least for a few hours. So starting off with your nonsteroidal anti-inflammatory drugs. Thanks, Kelly. Sorry, I'm confusing you. Um, the example of what the names here that I'm used to seeing in the drugstore, Motrin, Advil, Aleve, but really these inhibit COX-1, COX-2, stopping the conversion of arachidonic acid to prostaglandin in thromboxane, so that helps with pain. It's very common to give it orally, but there's also an IV version that we can give in the ICU, so just pour it all. It is something you got to think about. Somebody with renal dysfunction, you want to decrease your dosing. And if this patient is an appropriate candidate, we like to schedule the doses so that they get an example every 6 hours. It automatically comes to the patient. They don't have to ask for it. However, there are Beers criteria, which is a long list of medications that could be avoided or decreased in the elderly population, which is those over 70 years of age. So this is one of those that they tend to avoid, mostly because they have polypharmacy and complex comorbidities that can lead to like bleeding in their stomachs. Next slide, please. All right, so this is acetaminophen. It's readily available and relatively inexpensive. It does come in both the oral and the IV formulations for those that are strict NPO. And it's theorized that the most likely mechanism is a cyclooxygenase inhibition. But to be honest, they haven't actually confirmed the mechanism of action. So if you see it on an exam or anything, well, nobody knows. It's still theory. You need to be careful because it can lead to hepatic toxicity with overdose or chronic use. They say to stay within 4 grams in 24 hours and to keep in mind all sources that have the combination of acetaminophen with a different drug. For me, when I use the multimodal plan, I actually use 3 grams in a day. I do 1 gram every 8 hours because I am using it with other medications so that I can stay well below. It also has a opioid-sparing effect postoperatively, as much as 20% when added with narcotics. Next slide, please. The muscle relaxants. This is when I get consulted in the hospital, um, almost always when I go talk to a patient, they are complaining of deep dull, aching pain, not as much the sharp pain, because a lot of times we have that covered with various medications. But that deep, dull, I stick my hands in and I'm squeezing you pain, that is spasms, whether you can see it or you can't see it. And it's also that pain that comes out of nowhere and goes away out of nowhere. We it's again on the list to avoid with the Beers criteria, but I do use it in the elderly. I just decrease the dose. The mechanism of action isn't fully understood, but it's believed to inhibit nerve signals that contribute to muscle tension to allow for a decreased activity. There's some common ones I use in the hospital. Diazepam Valium is one of my favorites because it's a 2 birds with 1 stone kind of medication where it will treat your muscle spasms, but it'll also treat your anxiety and help you sleep a little bit, which is as good as medication in my book when you're trying to get someone to heal. But you can't give a sedative to everybody. So some less sedating medications are cyclobenzaprine and methocarbamol. My In my practice, I've found that cyclobenzaprine does not work as well as all the research touts it to work as. So quite often I switch people to methocarbamol and it works a heck of a lot better without and even though it says it's sedating, it is in my practice less sedating than cyclobenzaprine. We also schedule the methocarbamol. Unlike the Valium where people need to ask for it, I do schedule the mall and I will schedule the tizanidine, which is the alpha 2 adrenergic test. That's another nice one the non-elderly population. Next slide, please. The gabapentinoids, these inhibit voltage-gated calcium channels and excitatory neurotransmitters. We currently use to treat diabetic polyneuropathy, postherpetic neuralgia, and surgical pain. And this drug is one that I reach for when people come or are talking about like burning pain or anything that sounds like a nervous pain. It's not the dull deep ache. It's not the sharp pain. It's different. Gabapentinoids are excreted in the urine unchanged, and you do again need to make dose adjustments for renal impairment. They've been shown to reduce opioid tolerance and also to help with the issues around central sensitization. There is a black box warning on it that it can make you sleepy. So, especially when you combine it with opioids or other sedatives, or you have a patient who's elderly. And what I do here for someone who's never taken this medication before is I start with a very low dose, about 100 milligrams, and I'll spread that out 3 times a day. But if that still makes them too sleepy, I'll do it just at night, because that will help them sleep at night, which is when your pain tends to get worse because of hormone fluctuations. Next slide, please. So NMDA receptor antagonists, so ketamine also comes in multiple variations. You've got your IV, your oral, and there's also an intranasal spray. Really like ketamine because it is excellent for pain control and it works at the NMDA receptor instead of the mu receptor. So it's a totally different receptor that we're using to treat pain with. It also helps with depression and with PTSD. So it's like a really nice all-encompassing medication. However, um, it can cause really vivid, terrible dreams that can be very scary for people. And if the dose is too high, it can cause you to hallucinate. I've had patients who have seen horses clomping through their hospital room, or the walls are turning purple. So it's not necessarily like bad hallucinations, but it's definitely not right. And that is when you know you've gone too far and you want to bring it back down. One nice thing about ketamine is that it's relatively safe for the elderly, which like, everything else is not. So it's something that I can reach for them if we happen to have it. Sometimes, the hurricanes knock things out and we don't have that. And I'm not sure what kind of access you guys can get. But I understand that medicines can be difficult. We'll typically run this ketamine infusion for at least a day, up to 5 days, but there have been providers at other hospitals that have run it for weeks. Next slide, please. Tramadol or Ultram is the opioid receptor agonist. Its mechanism of action is to act on the serotonergic and noradrenergic nociception by inhibiting uptake, and it has an active metabolite that acts on the mu opioid receptor, which is about the 10th potency of morphine. So it's like baby narcotics. And a lot of people will reach for it first because they think that it's like easier on the body, and that's hit or miss. Some people will call tramadol tramadol because it can cause you to be really dizzy, and it has been associated with increased falls amongst many other things. It can cause serotonin syndrome if you give it to patients who are taking SSRIs or SNRIs. So it's just one of those drugs that's a little bit trickier. It's not as straightforward as people think. But if you do have an appropriate candidate for it, we will start 25 to 50 milligrams, and I'll place it every 4 hours as needed to help avoid oxycodone a lot of times. Next slide, please. So opioids, very important for pain, but just sparingly. We don't want to go overboard with this. First of all, once you flood your mu receptor, there's not, it doesn't help to just keep increasing, and it can, eventually there's a ceiling effect for pain control, but there isn't for the respiratory depression. So um, this is something we do want to incorporate into our plan. Many patients might be a little reluctant to take an opioid because of what they see in the movies and on TV, and they have fear of developing addiction because maybe their friend or their family member had it. So they will refuse doses. And what I do with that is I just sit and I talk to them about how there's like an appropriate time and place for these medications. And this major traumatic surgery you just had is a very good time and place to use it because I need them to be functional. Oral doses are superior to IV doses if it's a possibility because they'll last 4 to 6 hours versus 1 to 2 hours of IV. So what that means is they can basically get comfortable and stay comfortable, as opposed to the IV, they get comfortable fast, but it doesn't last long, and it can lead to dissatisfaction and seeking. So the three most common narcotics we use for post-op pain are morphine, Dilaudid, and fentanyl. Morphine can cause itching, so I tend not to use it. I really like Dilaudid. It's a moderate fast-acting and moderate lasting. Fentanyl I don't typically reach for post-op pain unless I unless it's like an infusion in the ICU for someone who's intubated, or I have somebody with extreme sleep apnea that I need to, I want to give them something, but I needed to go fast. Next slide, please. Um, so the role of active metabolites in the use of opioids, this is just something to keep in mind, especially ICU setting. Somebody can be on narcotics for a long time, and with their comorbidities, sometimes your kidneys are okay, and then they're not okay. Liver is okay now, but tomorrow it's not okay. So we're constantly reevaluating for what the metabolites will do, whether we've had patients that have had the metabolite of Dilaudid build up, and it really caused them to be mentally not there, and they didn't do well. So this is just a list. I know you guys get these slides, so it's for later for you to look at to see which ones have activity, which don't, and which are clinically important. Next slide. So patient education is part of the pain plan. So as I mentioned before, setting expectations is a big deal. I tend to sit down with patients. I'll give them educational material on their pain interventions and medications that I can use post-op so that we have that conversation before they're in pain. I've created brochures that the surgeon gives out at the pre-op clinic to talk about regional nerve blocks and epidural so that they've at least heard of it before. And then I'll teach patients how to use the pain scales and talk to them about like whether they like the procedure they're having is a very painful, moderately painful, or minimally painful, so that they have an idea. There is no such thing as no pain. That is when someone is in a coma, but we can, like I said, try to get pain to a reasonable level where they can function. And what I mean by function is, are you walking? Are you sleeping? Are you eating? Can you roll over? As you know, that other question was, what is the most painful thing is being turned. We want you to be able to just be able to get up and go to the bathroom. That is it with roll. And I also involve caregivers, especially in younger patients and in older patients or anybody that seems like they are very dependent or don't have a lot of trust in caregivers. It's important to involve the caregivers because we're all in the same team and they can also understand the pain scores and help with medication administration, whether it's reminding your patient or whether they're going home now and they're going to be helping to give the medication. And then, of course, knowing when to stop and how to properly dispose of. Next slide. So just one more question with the poll. A healthy patient with chronic pain is post-op from major abdominal surgery. So what plan is best for someone who's healthy but had a really big belly surgery and has a history of chronic pain? Do we want to start a fentanyl PCA and IV Tylenol? Do we want to start long-acting MS-Contin and a lidocaine infusion? Or do we want to restart their home pain medications, give them a Dilaudid PCA, and add some gabapentin and Tylenol? I'm just looking at my clock. I'm going to give it about 15 seconds. Okay. So the answer would be to restart home pain medications. That's it. Critical. It's something that sounds like you would know that or it's a dub, but it is very frequently missed. And oftentimes we'll start all these pain medicines at in the hospital, but they actually took higher doses at home. So you're underdosing them, you're putting them into withdrawal during one of those most important parts of their healing journey. So starting the home pain meds, adding a Dilaudid PCA will help with patient satisfaction. They can administer their own medications and then get contingent Tylenols for a more typical approach. Thank you so much. Now we'll talk about some nerve blocks.
All right, going on to some regional techniques, how to control pain in ICU patients. Next slide, please. So who are the patients who would benefit from regional anesthesia? These are post-surgical patients who've had either elective or emergency surgeries, and this can be thoracotomies, esophagectomies, liver resections, bowel XLAP and bowel resections, vascular surgeries, amputations, etc. So any surgery involving extremities, chest wall, abdominal cavity, pelvic surgeries, any of these patients can receive nerve blocks and would be beneficial for them. The next subset of patients would be post-trauma patients. Now, rib fractures are usually have very high morbidity because of the respiratory and pulmonary complications that are associated with it. And also, rib fracture is one of the most common traumas that are seen and that lands patients in the ICU. Other, traumas, hip fractures, usually seen in elderly, frail patients, they would definitely benefit from regional analgesia. And the last subset is acute procedural pain. Now, in ICUs, multiple times there are, burns dressing changes that are highly painful. Not all the time. They go to the OR and receive sedation. So having a nerve catheter for them that can be bolused prior to these dressing changes is helpful, and also helpful in controlling the pain as such. Sometimes for, groin lines, you can do certain isolated nerve blocks and procedures, electrophysiology procedures or vascular procedures can also have benefit from nerve blocks. Next slide, please. So we all know regional anesthesia definitely has some advantages. So what are they? Just I've listed out a few. They reduce the risk of persistent post-operative pain. So, and as we know, as Dr. Jaremko said, if pain is controlled poorly, it can lead to chronic pain. So it's important that we provide good quality, consistent analgesia in the acute phase. Next is reduction in post-operative pulmonary complications. A lot of the surgeries or traumas can result in, atelectasis or pneumonia, or if a patient is on ventilator. Providing adequate analgesia can help them get weaned off or can increase their respiratory, drive or, effort, and speed up recovery and shorten their ICU stays. Superior analgesia is provided, regional provides focused and high quality analgesia, and thus lowers the opioid requirements and the side effects that are associated with them. Overall as well, regional anesthesia has fewer side effects and it has higher patient satisfaction. And then, sorry, you guys not able to hear me? Okay. I hope you all can, so I'm just going to continue. And finally, studies have shown that there is reduction in postoperative neurocognitive dysfunction in major non-cardiac surgery with the use of regional anesthesia. Next slide, please. So there are certain limitations to using these regional techniques. Now, most often when we do a nerve block, the patients, especially the adult patients, they are either very mildly, lightly sedated, or many of them don't get sedation depending on what block is being done. And when this is done, this is to get feedback, which prevents us, from getting too close to a nerve and causing any kind of nerve injury. So in the ICU, when patients are either heavily sedated or on the ventilator, the risk of nerve injury increases because we don't have that feedback as we would have from a more lightly sedated patient. The second thing that could happen is the signs and symptoms of local anesthetic systemic toxicity can be masked, because we know the first and initial signs are restless, agitation, and that, if a patient is sedated, would not be evident. Many patients in the ICU have infection or, sepsis. At the same time, need pain control. But an absolute contraindication would be if there is infection at the site where you would want to perform the nerve block. If a patient has bacteremia, that's a relative contraindication. If they are already on antibiotics, nerve blocks can still be performed, especially single injections. Having catheters, usually a catheter, if it's placed more than 48 hours in the ICU, there is increased risk of infection. So you just have to be cognizant of it and monitor closely. Now, patients in the ICU oftentimes are hemodynamic unstable, either be it from the surgical procedure they've had or, inherent history or, so your choice of neuraxial techniques like epidurals, which cause a sympathetic blockade, or a thoracic paravertebral, which also can have similar effect, might be limited in these patients who are, hemodynamic unstable. And then finally, patients, when they are in the ICU, are either on some kind of anticoagulation or they might have pre-existing coagulopathies. So this would factor in when you're trying to choose what kind of technique would be used for certain patients. You might have to rule out, neuraxial technique and go more for fascial plane blocks or peripheral blocks compared to, doing any deep catheters or epidurals, etc. Next slide, please. All right, so this is a case scenario. This is a 38-year-old male with history of motor vehicle accident, pedestrian versus car, with left-sided 3rd to 6th rib fractures, left pulmonary contusion, and hemothorax. He is on multimodal pain management, but he is splinting and is hypoxic. What regional technique can you be used for controlling pain? I'm going to give you about 20-30 seconds to think about it. All right. So I have most of you saying all of the above and a few saying left paravertebral. So the answer is, in this particular patient, you can do all of the above because, the thoracic, and we'll kind of see what blocks can be done for, chest wall analgesia, but, any of these blocks will provide adequate analgesia for, left-sided rib fractures. Next slide, please. So here are some blocks listed for providing analgesia to the chest wall. On the right side, you can, sorry, let me just clear my screen, is the corresponding area that is covered by these blocks. Today, I will briefly, since we don't have a whole lot of time, I'll briefly talk about ESP, that is the erector spinae block, PVB, the paravertebral, and SAPB, the serratus anterior plane block. Next slide, please. So the paravertebral block, this is a very effective block. Now, what is the paravertebral space briefly? This is a wedge-shaped, you can see it on the top left picture. It is a wedge-shaped space. It contains both the dorsal and the ventral rami, and it also contains the gray and the white rami communicants leading to the sympathetic connection. So when medications are deposited in this area, you get a segmental, a unilateral block on the hemithorax. the one landmark that you should know is the posterior one, that is costotransverse ligament. You have to go through this ligament to deposit the local anesthetic, and the local anesthetic then is between the pleura and this ligament. So spread of local anesthetic is both cephalad and caudad, and you can see that in the X-ray, which is highlighted by the blue arrow. The spread is also lateral into the intercostal spaces. It can also spread medially, thereby the risk of epidural spread, and then anterior towards the vertebral body. Now, approaches to paravertebral, it can be landmarked. It can be also by ultrasound guided. The ultrasound, you can have the probe transverse or sagittal. It all depends on the comfort of and how you have trained for this block. Now, the ultrasound picture, I just wanted to highlight, this is when the probe is sagittal. What you will see is the transverse process on both sides, marked as TP. And the faint red line, the arrow is pointing to it, is your superior costotransverse ligament. And the shiny line below that is your pleura. So the space between is the paravertebral space. You entered this, like I said in the previous slide, you go through the ligament, and when you inject, you will see the pleura being pushed down, and that is the correct, placement of this block. It also causes a lot of chest pressure when you are injecting, so slow injections, and the patient will complain, and that again tells you that you are in the right space. All right, so next slide. Erector spinae block. This erector spinae muscle is basically a group of muscles that extends from the skull down to the sacrum. And this block, it's a paraspinal fascial plane block, where the injection is between the erector spinae muscle and the transverse processes. The blue line kind of highlights where the local is deposited. Now, this you can do from between T5 to T7 is usually where we want to do this injection. And one injection of about 15-20 mLs will give you 3 to 4 dermatomal spread above and below. So pretty good spread with this block. You do need to have a larger volume for this. And the area covered is shown in that green color, pretty much hemithorax coverage and extensive dermatomal coverage can be achieved with erector spinae. Now, this is also, it blocks both the dorsal and the ventral rami, and the idea is it's by diffusion of the local anesthetic towards, you are depositing it more close to the dorsal rami, but the diffusion can also, of the medication can also block the ventral rami, thereby giving it a more complete block. All right, so now the next slide. Serratus anterior plane block, again, the area covered is shown in the diagram there. You can always use it for, lateral rib fractures, chest tubes, any lateral thoracic incisions. The coverage is a little limited as compared to the other two. It covers the lateral cutaneous branches of T2 to T9, and along with there are also two other nerves, long thoracic nerve and thoracodorsal nerve. Now the injection here, in the ultrasound picture, you can see the top muscle is the latissimus dorsi, and the one below it is serratus. Now injection can either be above the serratus muscle or below the serratus muscle, because the nerve fibers kind of traverse through this, so you will, get those nerve fibers in either of the sites for your injectate. All right, next slide. So this slide compares, a few studies I have kind of put here that compares different chest wall blocks. The first one is a meta-analysis by Ding et al. They compared analgesic efficiency and side effects of paravertebral to thoracic epidural. And what they found was the pain control is pretty comparable between the two, but the side effect profile is a little bit better for the paravertebral. The next study is ultrasound guided erector spinae block compared to thoracic paravertebral. And what they found is the analgesic effects for both these blocks were pretty similar 24 hours post-op. Now, the paravertebral block is a little bit challenging, and also has certain limitations. So sometimes it's easier to do the ESP block if the efficacy is similar. And finally, the last one is a multi-center longitudinal cross-sectional study, which compared a serratus anterior plane block, paravertebral and thoracic epidural blocks for rib fractures. And they found that all these had the ability to reduce pain and improve respiratory function. Next slide, please. So I've just listed some abdominal wall blocks here. You know, we can't really talk in detail about them, but just to know, the rectus sheath is for midline incisions. So anteromedial abdominal surgeries, you can use this. The injection is between the rectus abdominis muscle and the posterior rectal muscle and the sheath, sorry. The transversus abdominis plane block, or the TAP block, it covers about T6 to T12. Now, there are multiple approaches to it. If your incision is more closer towards, you know, T6, T7, you can do a subcostal approach, and the red area kind of highlights that. And the classic lateral approach will cover somewhere around T9, 10, 11 incisions. And then the quadratus lumborum block, it has a little bit of a larger coverage. It can cover the thoracolumbar nerves from T6 to L1. Positioning is usually a little bit, you know, you have to have a little posterior approach, or patients have to be lateral to get to this. So if you're doing it in the, mainly if you were doing it in the operating room, you have to position the patients in the ICU. It shouldn't be that much of an issue. All right, next slide, yes. Now this slide, you can, you know, it's here, you can take a look at it in detail later, but it just compares these fascial plane blocks to epidural in terms of the spread. What is the risk of having neuraxial complications? So none of these fascial planes, you know, really have any neuraxial complications. The one that's obviously not listed here is paravertebral. That does have some spread. And then also somatic and visceral coverage. You can see that erector spinae does have both coverage for both, whereas serratus and the TAP only provide somatic coverage. And the little chart on the right kind of tells you why you would go for a fascial plane block versus neuraxial. And again, if there's a contraindication, if patient is on anticoagulation, or if they've had a failed epidural, then those would be some of the indications that, you know, you might want to go for a fascial plane block. Next slide. So another case scenario, 82-year-old male, past medical history of diabetes, AFib on apixaban, COPD, presented with hip fracture after a fall. His pain is poorly controlled with oral medications. Which block would you use to supplement his pain control? All right. So in this case, the correct answer would be C. Although you can use all of this, but in this particular patient, because he is on apixaban, you do not want to do a neuraxial technique, a lumbar plex epidural, or a lumbar plexus block, because that again is a deep block, and same rules hold for anticoagulation as would hold for any neuraxial block. So Peng would be the one to go for here. Next slide, please. So the hip fractures, why I want to highlight this, like I said earlier, there are older patients, they have significant comorbidities, they're frail, and providing adequate analgesia can help them get up and, be mobile, and also reduce complications and delirium. So that's why I just wanted to give you a few idea of how to pain control for these hip fractures. The blocks that can be done are listed here. The nerve supply for the hip is, complex. I'll just focus on the anterior capsule. That's the femoral nerve, obturator nerve, and the accessory obturator nerve. So PENG block targets these nerves here. Next slide, please. So this is brief description of the PENG block. Now, this, like I said, blocks the articular branches of the three nerves that we mentioned. The landmarks for this are your anterior inferior iliac spine and your iliopubic eminence. The injection is between the psoas tendon, as you can see the arrow pointing, and the ilium. So it kind of lifts when you inject, it lifts up your psoas tendon, and all the nerves are kind of spread around there. So this provides anterior capsule energies, and this kind of has been shown to cut down opioid requirements for pain management. Briefly about complications. So for any blocks that we do, there's always a risk of block failure or inadequate block, hematoma, infection, nerve injury, or local anesthetic systemic toxicity. For perivertebrals, I just wanted to make a separate mention. They do have the potential for sympathetic blockade and hypotension. There is a risk of pneumothorax with the pleura being so near. They also have potential for epidural spread, thereby causing side effects from that, and nerve injury. Fascial plane blocks, overall very safe to do, but there's always risk of vascular injury and organ injury depending upon what you're doing. Like a TAP, you can have an intraperitoneal injection, or in quadratus lumborum, you can have renal injury. And then certain blocks, the local anesthetic spread could cause some muscle weakness, depending, again, where your site of injection is. Next slide, please. So finally, just to summarize what all three of us kind of talked about today, pain is prevalent and it's often undertreated in critically ill patients, and inadequate analgesia can cause long-term chronic pain, psychological distress, and worsen morbidity and mortality outcomes. And obstacles for adequate pain control can be patient communication, multi-organ dysfunction, use of high opioids, and psychological distress. Dr. Segna kind of talked about the multimodal regimen, that, there are different medications on the ladder that can be used. And combined, they have more of a synergistic effect as compared to if you had just used one or two of these groups of medication. And finally, regional anesthesia. This provides, it's a very useful tool. It provides high quality anesthesia. It's specific to the location, and it has lower side effects and decreases the use of oral and IV pain medications. Next slide, please. And thank you. That's it. If you guys have any questions, feel free to unmute or put it in the chat.
Hello. So I have a question about the regional anesthesia, or analgesia rather, sorry.
Sure.
So for rib fractures, for example, where healing takes a long time, these techniques you described, I don't know, but I thought they last for about 24 hours or so. So I don't know Like if you have a patient who has rib fractures that were not fixed, what is the benefit of doing the block if it's not going to last for too long?
So, yeah, good question. You can always put a catheter, nerve. So that's what we usually do. We will put a peripheral nerve catheter either in the paravertebral space or in the erector spinae catheters, and you can have the catheter there for 3 to 4 days, 5 days, and during that time you overcome the acute phase of pain control. You kind of control the respiratory issues, and then in about 5, 6 days, when the pain control is adequate with oral analgesia, then that catheter can be removed. But I agree with you, a single shot does not really benefit. It helps just for maybe the 12 to 24 hours, but ideally you would need to place catheters for them. Do you guys use catheters there?
I haven't seen, but I don't want to say no. I think some people do. I don't
Yeah.
have the skills, so I can't comment.
So yes, we would recommend catheter and using a pain pump, So if the patient is able to use PCA, it could be connected, or you could have a continuous infusion depending upon what your facility has and is available there.
Um,
And I would say,
I would say,
oh,
I was just gonna say that I would consider a single shot nerve block if someone was at imminent risk for being intubated and they were in extreme pain, just to, I could add some adjuncts, or even not even 12 hours is enough to get them, first of all, not intubated, doing some pulmonary toilet and getting ahead of the pain. So just to buy some time, even though we do typically use pain.
right. Because if they're splinting and they're taking shallow breaths, then they're going to have more atelectasis. They're at higher risk for pneumonia or other complications that then leave them in the ICU much longer. So if we can get through that acute phase, like Dr. Segna and Dr. Prasad said, with a combination of multimodal and regional, then sometimes we can avoid those additional complications to the rib fractures and then come up with a pain plan that they would be able to go home with for that more chronic pain with healing. Great question. Other questions?
Okay, thank you. I'm Henok from Ethiopian team. My question is about the regional anesthesia or analgesia, as mentioned. So usually we are giving this regional analgesia for patients that are intubated that will not tell us about the early toxicity features. So how do you encounter those toxicity features of the local anesthesia? Especially we are usually using bupivacaine in our setup. So how do you want to manage also the toxicity symptoms, the toxicity adverse effect, and also the early effects? How do you want to test these effects? The other question is we don't have a good exposure for patient-controlled analgesia. So how do you manage your patients, especially not to overdose their opioids and so on and so forth?
Good question. So whenever you do regional anesthesia, you want to, first of all, calculate your dosing, right? When we place a catheter, if we are doing that, the initial bolus dose for ropivacaine, if you're just using plain ropivacaine, the dosing is about 2 to 2.5 milligrams per kilogram. You don't want to reach that highest dose. You want to give a lesser bolus, and then if you're not having a continuous infusion, you again have to calculate the max dose and spread it out if you're going to do intermittent injections to maintain that catheter. Very rarely you are using up to the maximum dose. Now, there are certain conditions where you want to decrease your dosing, especially patients with, cardiac heart failure, renal failure, liver dysfunction, you do want to cut down your dosing. So the first step would be to calculate the dose, put in these comorbid conditions, decrease your dose, and then go from there. It does become complicated. Yeah, go ahead.
Oh, no, I was just going to say, I think it does bring up a good point to watch for symptoms of local anesthetic toxicity, which we typically see as neurological issues up front. So confusion, sometimes they have tinnitus, perioral numbness, metallic taste in their mouth, and hopefully that's caught prior to any of the cardiac issues such as arrhythmias and obviously coding or seizures. And so if you're concerned about it, the treatment is intralipid, which is a medication to treat LAS that binds the local anesthetics and removes it from the cardiac musculature to try and prevent some of that and redeposits it in the skeletal muscles. Now, we know that sometimes not every location doing regional has access to formal intralipid. And from some of our colleagues who have done global anesthesia and regional have seen that the high lipid content in TPN can sometimes be used to help in the absence of formal intralipid for local anesthetic toxicity. So I just wanted to mention that there, but it's a great question.
Yeah, and to your point of, recognizing this in ventilated patients, you just have to, be careful with your dosing. Because yes, we won't see those neurological symptoms. And if it's a, sicker patient and does have some cardiac instability, then again, it becomes even more difficult. Is this arrhythmia because of the, inherent condition or from local anesthetics? So you want to rule that out by keeping your dosing low. And the second part was, can you repeat the second part of the question? I know you had two-part question. All right. Any other questions? Hope this was little helpful. Some of the medications, etc., available here might not be there, and some things that you guys have available, we might not have it here. So it's just an idea how to approach these patients.
And our emails are here in the slides that you'll receive. So please, if you have any questions, feel free to email us and reach out. We'd love to hear from you. And thank you so much for having us here today.